What's some standard documentation for your workup to establish the need for care? So let's cover some of those, okay? So administrative forms, HIPAA, insurance information, patient information. Legal forms, assignment of benefits, attorney lien, limited power of attorney. Now the assignment of benefits, so you get paid from the insurance. Attorney lien, to make sure that they pay you. The limited power of attorney, you only do that with attorneys you don't know. And what that does is it gives you access to the billing. Was the bills paid? How much was it billed? In other words, you have limited power of attorney. So now you can see what was paid, what wasn't paid, and when was it paid. So you can get that from the insurance company now. If you have limited power of attorney, you just have the patient sign it. And you can get that information from the attorney. So that's good to know. Clinical forms, patient history, family history, patient questionnaire. Accident injury related documents, accident injury questionnaire, mechanism of injury, pre-existing injury, short form 36 for pre-existing. Now it doesn't have to be short form 36. Short form 36 is an ADL worksheet, right? How many different types of ADL worksheets are there? There's all kinds. Just be consistent. Take one and be consistent with it all the way through, start to finish. That's just a really good, well-known one. Okay? Accident related, low impact injury factors, accident report. Accident report. Functional capacity forms, visual analog scale, pain disability questionnaire, health survey 36, neck disability index, oswestry, low back pain. Those are the common ones. If you have an extremity, then just get a functional capacity for the extremity. You can just Google it. Functional capacity scale index for the elbow. And there'll be a PDF pop up, and then just use it.
If you've got neck injury and low back injury, do you do the NDI and the oswestry, or you just do one?
Do you do what?
You do two. Let's say they have a neck injury and low back injury. You do oswestry, and you have to fill out a neck disability.
Oh yes, yeah. You're going to fill out the individual functional capacity index for that anatomy. So yeah. If you have a neck, make sure you do the neck, and if you have a back, do the back. So you would do both. If you have a neck, back, and elbow, do all three. Okay? If you don't have the documentation, what do you have? No need for care. Better to have it than not have it. You don't have the need for care. Now, if they don't have a problem, let's say you have a patient come in and they don't have no low back symptoms, complainer, don't do oswestry. Okay, so if they do have subjective or objective findings, do it. If they don't, then don't. Okay?
Those all have to have individual signatures, the legal forms there. Those
Yeah.
are all separate sheets, separate
Right.
every time.
Right.
Not all combined in one. I've seen that before. Like,
Right.
Okay.
Yep. I just put in standard examination procedures. I was amazed how many doctors, when they came to me, didn't even do standard procedures. I actually had this true story. I mean, some of the stuff that chiropractors do, I'm telling you. I'm amazed that 8% of the population sees chiropractors after 100 years, the stuff that I hear and see, which is a testament to the power of, the chiropractic, the profession, not the people, that it actually works. One of my clients joined, and he's a subluxation doctor, so they're out in another world. Is he doing range of motion? No. Is he doing muscle testing? No. Is he doing nerve testing? No. Is he doing orthopedic testing? No. I said, what the hell are you doing?
So how did they find out?
Subluxation station and an x-ray.
What's the subluxation station?
It's a gimmick. It's a gimmick. It's a marketing gimmick is all it is.
No, but what is it? No, seriously.
It's just a little device, and they combine range of motion with surface EMG and thermograph and thermography and put it on a scale. None of them are science. None of them are science-based. And, they're trying to... But that was what he was doing. An x-ray and a subluxation. You know what I said to him? I said, and he joined the practice management group that taught him that's to do, well, it was a subluxation practice management group. I said, you know what I would do? If I was the insurance company and I found that out, you know what I would do? I'd subpoena his records and get him in court to find out who his practice management company is. Then I'm going to the practice management company and I'm going to subpoena their records and I'm going to find out who all their clients are. Then I'm going to subpoena and go after every one of their clients. This is my road in. I'm going to go after every one of their, because I know if he's doing it and that's what they're teaching, where's all the money? It's not just him, it's everybody, because that's what he's being taught. Then I'm going to subpoena the practice management company to get who the clients are. I'll subpoena their bits of their records first to substantiate it. Then I'm going to go for all their records that they don't have the need for care, yet they're billing for the services. And I'm going to come out big. I said that's exactly what I would do if I was on the other side. That's how I'd get millions and millions of dollars back from all you guys. Do you see how that would work? You know how easy it would be to get that money back? No neurologicals, no muscle, no range of motion. That is like taking candy from a baby. Now, range of motion, well, we do all of them, right? You guys are paying attention. Everybody's familiar with active. Not many people pay attention to overpressure. That is a major chiropractic finding, overpressure. And what is even a greater chiropractic finder is joint function. Well, what's the only way you can find joint function? Motion x-ray. Well, what happens if you're not doing overpressure and you're not doing motion x-rays? You just missed two of the biggest chiropractic findings there are, meaning the need for care. You just missed it. How important, that's called sensitivity testing. That's what that's called, yeah.
Pressure, is there a support behind that from a study or something like that?
Overpressure? Guyton's physiology. I think actually somebody in here called me, I think it was somebody in here, and said, some of these questions really worry me. And like the doctor I told you said, he's been out 2 years, he goes, how do you determine the patient's treatment plan? A doctor. I'm like, are you kidding me? I'm like, don't tell anybody you asked me that question. And I had another guy call me and said, where do you get the justification for the, was it for the 3 ranges of motion? It was for the, not you, for the 3 ranges, was it you?
I asked you if there was orthopedic tests that you're doing for the overpressure.
No. One doctor called me and said, where's the source, where's the scientific source for the 3 ranges of motion? I said, and you're a chiropractor and you're asking me that? Are you kidding me? You guys ever hear of paraphysiological joint space? I said, go to Guyton's physiology. 3 ranges of motion. Active, passive, overpressure. They call it paraphysiological joint space. They typically don't call it joint motion. We say joint motion because patients won't know paraphysiological joint space, right? So, but that's a major chiropractic issue. I mean, we're good at the small findings, joint mechanics. That's what chiropractors are good. Our findings are not the gross findings, like muscle weakness, gross range of motion. That's not the chiropractic patient, routinely. So you got to get good at joint findings, joint tests, joint findings, sensory, motor. That's where you find the data to support the need for care. So, muscle testing. Do we get much in muscle testing? No. What did I tell you earlier? You're not going to ever give a impairment rating for muscle weakness. Muscle weakness based on the AMA guides testing 0 to 5. When you'll test, do you guys test muscles? That should be a component of what you do. And what's the way you test it? It should be AMA based. Everything you should do should be based out of the AMA. because that's the high third-party credibility source. Always go to the AMA for the source. So when you're looking at testing muscles, you use the AMA guide as what their recommendations, that's 0 to 5. And how do they test? It's a physician function. So is it acceptable to use machines to test muscle strength? According to the AMA? No. It's a physician function. It's a physician function. It's not a machine function. Now, will that mean something to a smart attorney on the stand if you used a machine to test muscle strength? If I'm an attorney and I know this, am I going to get you? Yeah, I'm going to get you. Because that's not the authority, that's not the science. I'm going to get you. Now, how long am I going to stay on that? As long as I can. As long as I can. What angle am I going to come at you with it once I see it's a weakness? Left, right, from the bottom, I'm going to come at you from every angle possible to really tear you up. And then what am I going to do? I'm going to take it and I'm going to swipe that over the rest of your documentation. That's how you get destroyed. And that's one of the ways. There's several ways of an attorney attacking you. And by the way, is it probably important to know how the insurance company or the attorneys are going to try to diminish their financial responsibility, whether it's through a narrative report, deposition, or a trial? Is that probably important for you to know? Yes. So you can do what? So you can defend against it before it happens. In other words, load up before it happens. Right? Load up. Load up meaning know the common 2 or 3 way. Well, that's one common way right there. You don't have your science down. They're going to come at you left, right, top, bottom, and then they're going to take it and smear that across all your other testimony as much as they can. That's one way of diminishing you, your credibility, and their financial responsibility. So, reflexes, you should test your reflexes. Are you guys testing reflexes? You should. Cranial nerves, you guys testing cranial nerves? Okay, if it's appropriate, if there's an upper extremity problem, head, neck, if there's an accident and there's no symptoms, nothing with neck, shoulder, or nothing, is there a need to test cranial nerves? No. See, it's called a regional exam based on the problem. So if I got no problems and no injuries here, nothing whatsoever, I'm like, well, why would I test cranial nerves? Well, there wouldn't be a need to. If it was just low back, or let's say I just have an ankle problem. They come in an auto accident and they just have an ankle problem. You think you need to test cranial nerves? No. It's called a regional exam, right? Orthopedic test. What are the tests you're going to have the highest sensitivity to with the orthopedic test? The compression test and overpressure test. Whatever test those are the tests where you're going to get your finding. So why do you need to know this? This is where you need to be searching extra hard in your documentation. When you're doing a test, pay a lot of attention to the compression test and the overpressure test. Whatever they are, pay a lot of attention to it. That's where the findings are. And remember, it's joint dysfunction is where the problems are. And by the way, in the initial exam, maybe you'll find active range of motion problems because they're more acute. Go 30 days down the road. What happens with active range of motion? It goes back to normal. So if you only did muscle testing and active range of motion and no motion x-rays, what do you got for a case? 0. You got nothing. So orthopedic tests, x-rays, static, dynamic, those are common. And remember, I get this question a lot too. What x-rays do you take and when do you take them? Well, the standard x-ray, and we're talking about general cases, so the standard x-rays is the Davis series for an auto injury, right? Low back, AP lateral obliques, especially if there's any radiating pain. And then I'll include with that the motion study. Like in the low back, you can do a flexion extension motion study. I like doing left and right lateral bending motion studies because it's easier to see the biomechanics. But in the beginning, you'll first take an x-ray for a very different reason. I'll take an x-ray on 3 different occasions. All of them are for 3 different reasons. So the first time they come in, I'm doing it for trauma. fractures, dislocations, avulsions, gross ligamentous laxity, trauma reasons. That's the reason I'm taking the Davis series and the motion series first. Now, after the first re-exam, I like doing a motion study on the re-exam for a total different reason. Because now I'm not dealing with reflex spasms that alter or inhibit motion, true motion. So things have settled down, they're not as in much pain. Now I'm doing an x-ray not for trauma, it's for biomechanics. So here's another question. Well, what if the accident or the injury was 3 months ago and they came in? And they're kind of toward the end and not having much inflammation phase, right? Well, then I will do the first one to check biomechanics because I'm not dealing with as much muscle splintering and all that. But on the first re-exam, I always like to do the motion study, and I only will redo the motion study. And it's not for organic purposes, it's not for fractures, it's not for dislocations. It's to check the biomechanics of the spine. It's therapeutic, it's clinical. You know, what areas do I need to work with? And then I like to do a X-ray motion study and static at the end, especially if you had static findings, but especially a motion study at the exit exam at MMI. Now, again, it's a total different reason. What's the reason at MMI? Now I'm doing it to quantify the injury. For what? For impairment ratings. Need for future care, exactly right. It's a total different reason. So all three reasons are different and why I would take x-rays and when. So there's your static. I like to do blood analysis. The number one test is the those are the two essentially what we call personal injury blood tests. Sedimentation rate and high C-reactive protein. Those are trauma tests. Sedimentation rate's more of a trauma test. High C-reactive protein is an inflammatory indicator. It's like one of the highest, if not the highest, inflammatory indicators. It's like the highest LabCorp inflammatory indicator. It's real sensitive for inflammation. Well, how important is it if you had a positive inflammation after an examination from a blood test? How important is that test? What factors does it fall into? That's very important. Subjective or objective? Little or a lot? It's 100% objective, and what else that we need as chiropractors? 100% credible. You know how much that's going to do for your personal injury cases? I'm recommending that you guys really start recommending these tests. Now, sedimentation rate is protein, right? You have trauma, protein breakdown, so it measures the protein in the blood. When I did this, I kind of found that it's more sensitive immediately after an accident, within a few days to a week or so. If the accident was like 2 months ago, then the sedimentation rate is kind of not there. Okay, and you can have a high sedimentation rate if the person's working out a lot, right, from protein breakdown and stuff like that. But it's a great, now remember, your diagnosis and treatment is never based on one thing, is it? It's never based on, it's the story. But if you look at the weights of a story, what carries more weight? How much weight does a sedimentation blood test, how much weight does that carry when it mixes in with the rest of the story? Trauma, signs, symptoms, orthopedic test. How much weight does that weigh in now? A ton of great weight. Same with C-reactive protein. It's an inflammatory indicator. And all I did at the end of day one, after you took the x-rays, I just had the prescription. Said, go head over to LabCorp. I found a local lab place, whether it was LabCorp, ClinicCorp, or if there's a local medical doctor's office that takes lab. Don't recommend taking lab work in your office. Do not. You got OSHA, you got all kinds of, some states you won't even be able to do it. But if you can order blood tests, I recommend you do it. Right after you finish the consultation and exam, give them the prescription and have them, and if you at least do one, do the high sensitivity C-reactive protein. because it's an inflammatory indicator. It's a great third-party objective supportive component to what you're doing. Has anybody started doing that yet? You have you?
Yeah.
How's that going?
Good. So it's, sometimes you get, the tests come back positive or negative. Most of it negative for inflammation on the injury.
You got one though.
Yeah.
Yeah, I'm okay if it's come back in negative, but if you got one, you got it.
Do you,
One other thing I will say about it too. I've said this over and over. It's the number one thing you can do for credibility is order a blood test for your patient or in court. I'm telling you, your credibility will, because who does blood? In the medical doctors. You're a real doctor if you do blood tests. Not a, I mean, I'm telling you, you want to increase your credibility? Order the damn test, man.
So I've been in a car accident before, just on the medical doctor route, and I've never had my blood drawn. It just seems like it's so far outside of the standard of care I've seen and experienced. As a professional, I've never seen someone order a blood test for a low speed car accident to figure out there's inflammation. Can you please help explain to me the thinking behind, I understand it's a piece of the puzzle, but, so let's just say it's off the scale, like it's completely disproportionate. What value does that give to the case?
Well, the first value is it's tremendous objective, 100% objective, 100% credibility to support the rest of your story. Okay? That's the number one thing it brings to the case. Now, is there something specifically that you can do with that? Well, your treatments are going to help with inflammation and pain, right? So that'll help measure an inflammation and pain, especially if you're going to prescribe any anti-inflammatory supplements, nutritional supplements. But it's another biomarker it's a biomarker. It's another measuring tool. It's only one, but it's a very good one. Okay? Huh? What is it? The number one positive test? No. What's the number one positive test? Altered arthrokinematics is the number one, highest probability, highest sensitivity, totally objective. Altered arthrokinematics. How are those joints moving? That's the number one, highest probability. So if I had to put the blood test in as far as probability, I'd say it's at 50%. But it carries a ton of authority. Authority. Even if it's negative, guess how much more authority you have in court because you ordered the blood test. I'm telling you. Just because you ordered a blood test, you're just going to have a lot more credibility as a doctor.
It doesn't change your findings or the way you treat the patient, though. I can see the attorney saying, what was your goal in ordering the blood test?
Well, it could. If you're going to do nutritional supplements and use anti-inflammatory supplements. But if you're, that would help. But as far as the treatment, it wouldn't change the treatment. It would just help. It'd be another marker of how the treatment is going.
Sure.
That's all.
Paul, can I throw something in on this? I work at a big PI place right around here, and sometimes, like, we had a lady the other day came in and slid on the bus, and she said she got a contusion on her butt. So see, sometimes people come in and they say they're having this and they're having that, and, but when you have a test like this and it shows something like that, I think that would, especially in a jury's mind, or the lawyers are probably used to seeing some fake cases or something like that.
See, that's a good example because in that case, if you ran the sedimentation rate within 48, 72 hours of her slamming, you're going to have a positive sedimentation rate. How easy now is that supported? With the whole history. Remember, it's the story. Remember, it's never one test. Never. It's the story is how you win. It's the story. Mechanism of injury. We're going through all that. But it's mechanism, signs, symptoms, objective, subjective, blah, blah, blah. But it just carries it has way more weight in the story. That's all I'm trying to say. But patients, credibility skyrockets. Attorneys, credibility skyrockets.
Jason, that test, it isn't, we don't do tests with a goal in mind, as opposed to, we do tests because we suspect we need to verify the lower level tests justify why we would do the next test. So if there's a mechanism of injury and there's pain in that site, and that would suggest to do the next test, which may be a blood test.
Well, the two reasons you're going to do a test, right? Number one is for the diagnosis, and then the other one is to quantify the diagnosis. You'll do a test just to quantify something, and that's kind of what the inflammatory test is.
So are there published standardized rates for?
Oh yeah, oh yeah,
CSRs?
oh yeah.
I don't know, I mean, obviously I'm not.
When you get a blood test, it'll just give you normal. It'll just, I mean, you don't have to know anything. Just order the test. And I find most chiropractors don't do blood tests because it's not in their paradigm. And then they're afraid because they don't know how to read the test. And all I'm telling you is when you get the LabCorp back, it'll say, here's the test, here's the normal range, here's their range. Is it high, low, little high, or little low? I mean, it literally just tells you. It's like, it's talk and tell. I mean, it's unbelievably simple. And then you just have to know a little bit of basics of, well, what is that? Well, it's an inflammatory indicator. If your body. See, you can also have systemic inflammation and that be positive.
Yeah.
That's the number one test for heart disease. Likelihood of a heart attack. Because heart attacks start with inflammation.
Right.
So it can be, high C-reactive protein can be systemic or traumatic. Sedimentation rate is going to be traumatic. But I'm still going to have unbelievable third party, because remember, if I got this inflammatory indicator that's high sensitivity and for inflammation, now let me match it with an overpressure or compression test, some pain, and altered orthokinematics. How well did I just complete that trifecta? I just clicked it out of the park. That last piece of the puzzle just banged it out of the park. You see? It takes it way down the road for you. Additional testing is needed. MRIs, you guys know how to do that. Urine analysis, not much out of that. Usually you're looking for protein. I found that you're dealing with major trauma. I did urine tests for a couple years, and none of them were positive. None of them. And I just stopped doing them because I just had no. You're talking about some major trauma, I think, in my experience, to have any type of protein in the urine after trauma. That's what that's for. But you might want to consider that. NCVs, EMGs. Remember, what percentage of patients have positive NCVs, EMGs? A low percent. 16% have nerve injuries. But you guys have known that, and I recommend that you get the consult from your team neurologist, right? If somebody has tingling or numbness, that's your indication to go, hey, Miss Dr. Neurologist, let me know what you think. I want a consult. Tell me what you think. That's very good. But the vast majority of time, how many times does a patient have tingling or numbness? You do an NCV and it's normal. Any of you guys order NCVs? They're like almost always normal, right?
Yep.
Yeah. Do you know why? The patient will have tingling or numbness. And you'll do an NCV, and it comes back normal like almost all the time. Do you know why? What?
Probably done incorrectly.
No.
It's got nothing to do with the conduction.
What?
The tingling has nothing to do with the conduction.
Meaning?
That you could have the tingling, but the velocity of the signals are normal.
Yeah, you're dealing with two different neurological pathways. The diagnostic pathway is testing the C fibers, and the acute pain is the A fibers, right? And it's two different pathways, and that's why they'll have tingling and numbness, and it'll almost always be normal. Because the pathway for testing it is not the same pathway for the sensory that it's almost always on. That's why. Now, does that mean you don't do it? Well, I'll tell you, I don't recommend to have an NCV or MG. Who do I like that recommend that? My neurologist, my guy that I said, hey, what's your opinion? What do you think we need to have done? That's the guy that I want. Is that better for your case? Yes. Who do you think is better to order an NCV or EMG? You, the chiropractor, with your authority, or a neurologist? Wake up. Wake up. Thank you, subluxation. Thank you, subluxation. You know what I mean? if there's any chance of a mild concussion, right, you want to do the preliminary Glasgow Coma Scale. That's like a good generic one. You can just print it off. It's real simple. Sensory motor, some basic stuff like 15 questions. And then you want to get a neuropsychologist as a consult. But you want to search for mild concussion symptoms. So what are some mild concussion symptoms? Dizziness, did they black out, even if it was for a second? Because what had to happen for the person to black out? Trauma. What kind of trauma? Brain trauma. Brain trauma is called what? A bruise, a brain bruise, right? What impairment rating do you automatically get? You get 6% impairment rating automatically from brain bruise. So do you think you might want to search for that and pay attention for, did you black out, dizziness, blurred vision? Okay, you want to search for that information. That's called high sensitivity searching. So if you don't even know, look how bad this gets. You don't do motion studies. You're only doing active range of motion, no joint motion, and you're doing reflexes and that's kind of all you're doing. And then with the nerve testing, and then you're also not doing any digging for mild concussion or brain bruising. What kind of case do you have right now? Do you know how many chiropractors, that's exactly what they do? They'll do static x-rays, that's it. Active range of motion, reflexes, maybe muscle test, maybe. And that's it. Guess how quickly they have nothing to support a case. This might be important for you to know so you don't do that. Then also, is it also important to know to go, hey, there's a big market out there. Because guess what mostly the attorneys you're going to talk to, guess what they're dealing with? Guess what kind of chiropractors they're dealing with, what kind of documentation and reports they're dealing with? That. Well, guess how quickly you're going to show him that that's crap. See? So refer to the medical team, consult as necessary. So the medical team, what's the main thing that you want to happen with your medical team? You want to be able to send your patient somewhere where the person does not say, do not go to a chiropractor. If you've been practicing any length at all, you know that's what happens. That's going to hurt your case. So you need to make sure you have, number one, a medical team to help support the case. The number one reason you need a medical team is so you can refer them to somebody and then go, don't go to the chiropractor. And here's what they say now, not to offend you. Say, I tell you what, just chiropractor's okay, but tell you what, wait till you feel better before you go back. That's the crap they say. That's what they say now. That's how they offend you now. Well, you have to establish a team member. Remember, in other words, you got to go meet them. And I explain all this in my tapes, my webinar on how to do the team members. I'm going to go meet them. I'm going to go make sure that they're okay with chiropractic. I'm going to get their agreement they're not going to say anything negative, and they're not going to change their schedule. And if they can't say yes to all three of those, they're not getting my referral. And if they say yes to those, I'm like, good, we'll play ball. Now he's not going to screw me. Because that's the first thing I want. I just don't want to send them over there and they go, don't recommend chiropractic care for 3 weeks or whatever. Guess how well your attorney's going to like that? That's the crap that happens. When you don't take control and you don't know what's going on, this is the crap that happens. So pain management I like using for pain medications, muscle relaxers, anti-medications, or trigger point injections. Make sure you have a pain management guy you can refer to for the inflammatory phases, for that type of stuff. Does that mean we keep them medicated the rest of their life? No. Is medication good in the inflammatory phase for pain and inflammation? Yeah. Don't be crazy. Don't be a wacko. Does that mean you want them on for all three phases of healing? No. Neurosurgeons, disc bulge, or herniation. Neurosurgeons are way more favorable to chiropractors than orthopedic surgeons. Neurosurgeons, way more favorable. Recommend you work with a neurosurgeon for disc, not an orthopedist. Orthopedist I use for extremities. and it's not competitive also. Orthopedists will send them to the physical therapist that they have stock in that clinic. That's what an orthopedist will do. Extremities, I'm not a big extremity guy. I'm like, no, you take care of the extremities, you know. So I like using the orthopedic for extreme. What extremities are typical in a personal injury case? Foot, ankle, knee, shoulder, wrist, right? Wrist, shoulder from the steering wheel, foot from the brake, knee from the dashboard. Neuropsychologist, mild coma. So if I have any signs or symptoms for mild concussion, not mild concussion, I want a neuropsychologist. If you don't have a neuropsychologist in your area, then a psychologist that works with personal injury cases. So.
These guys are rare.
Neuropsychologists are very rare, only in really big cities. Psychologists, though, aren't. You'll be able to get some, these are behavioral studies that most psychologists will be able to perform. They'll know of and be able to perform. Daily treatment documentation. So that's your SOAP notes. So what does that include? Your pain scale, 1 to 10. We like to use 1 to 10 because there's more variables versus mild, moderate, or severe. Remember, if there are 7 and now there are 6, is that a need for care? Yes. Yes. Visual analog scale. Palpation, pain, tenderness, muscle spasms. So remember, one component of the SOAP note is an E&M component, right? The A, so there's the subjective, and then the A, subjective, S-O, or the objective, O, there is the E&M component. You're supposed to have 2 E&M components in the objective category of the SOAP note, right? Which ones have the highest probability of you getting a finding? Huh? Palpation what? What's palpation? What's the finding? Palpation is not the finding. Palpation is the diagnostic tool. What's the finding? Tenderness. What else? Tenderness. We're going to say inflammation. Pain. Inflammation. What else?
Restriction.
Huh?
Restriction.
Restriction. What kind of restriction? Active range of motion? Won't be active. Joint motion. Joint. You and I know them as fixations, right? Fixations. What are you going to most likely have a positive finding in? Active range of motion or a fixation? Which one do we have a positive finding in the longest? Active range of motion anomalies or fixation anomalies? Fixation anomalies. So if you don't know how, or you don't, and you don't quantify it, what kind of biomarker do you have now? Nothing. You don't got it. But now if I do, I palpate and I got the fixation, C5, 6 on the left, I got a cervical fixation there. That's one of the ranges of motion. That's called joint motion, right? How would you quantify that? Would you want to quantify it? Huh? Quantify everything. So, how would you quantify a fixation? That's a low way of quantifying it, right? You only got 3 variables. That's a low way, but it's better than what? Nothing. What else?
Lack of motion between 2 segments.
I know, but I said quantify it.
Dual inclinometry.
I would have thought you'd have gone to back so you don't take this abuse anymore. You're like, he still wants more abuse. Tanez, get up here so I can abuse you some, and you and him. Come on, I want to abuse both of you together. What'd you say?
Dual inclinometry.
That's the diagnostic tool. Is dual inclinometry going to be, what motion is dual inclinometry going to pick up? Active, passive, or joint motion? How quickly is active going to be gone? Normal. Real quick. So how effective is that going to be? So you want to take it initially, right? And on the re-exams. But is that going to be a good finding to hang your hat on? Active range of motion and dual inclinometers? No. What joint motion is the motion that's going to be there the longest? Or what motion? It's joint motion that's going to be there. What's the way to detect it? Well, the best way is flexion extension views, but from a palpation standpoint, what's another way of quantifying a fixation? Are you testing for fixations? How do you quantify it? 0 to 10? Do you ask the patient?
No,
You do it yourself?
I just gauge it myself.
On what?
If it's complete walk, if there's, a decent amount of motion.
Okay?
Mild, moderate.
That's okay, but he needs a legend, right? So now, but how that's just on him, and I'm like,
So I
but
documented.
better than nothing. Hang with me. How do you document fixations? Do you check fixation? Do you check them? So you check for them. Do you document them? And do you quantify them? So when you document them, how do you like if you see a fixation in the neck, what do you write down?
Limited motion on C5, 6, 7. That's it.
He said limited motion. What word would I want to use better than limited motion?
Restricted.
No.
Fixation.
What's limited motion mean? Is it definitive for active, passive, or joint motion? Neither. He just said limited motion. So how can I be more definitive with my diagnostic tool? What would I say? Limited joint motion. Because you're not testing active range of motion. You're not testing overpressure. I'm going to say limited joint motion. Do you understand that's an individual category? Do you understand that that's a big diagnostic category for chiropractors? Joint motion. That's a big category. Diagnostically, therapeutically, that's a big category. That's where all the problems are in your personal injury. It's not an active range of motion. So, what would be another way is anybody else documenting fixations? How are you doing it?
Mild, moderate, severe.
Okay, that's what he said.
Oh,
Yeah.
yeah.
What are you doing? Oh, by the way,
Is that
wait a minute. Is it you mild, moderate, severe, or is it asking them?
Me.
Okay. What is preferable for you and your scale, like what he did, or get the patient to say it?
It's an objective test.
That's subjective, right?
Okay. How are you quantifying it?
I've got 3 parts to quantifying that.
Oh my God.
Yeah, oh yeah. 3.
Can you tell us by dinner time?
Mild, moderate, severe.
Okay.
I'll ask the patient. I'll do a PDA glide on
Okay.
the joint. Ask them
Okay.
mild, moderate, severe.
All of those, let me
Ask
just
them
say,
how it'll equate on a scale from 1 to 10.
okay,
So it does-
here's the deal,
And then-
is with grading fixations,
Do you want me to?
I don't know of a third-party grading source. AMA Guides does not give a third-party grading source for a fixation, right? Okay. So you can grade it however you want, but what is the scale that I prefer? I prefer the 0, 1, 2, 3 scale. That's the scale that I like to use with functional tests. That's what I like to use in addition to the orthopedic positive or negative tests, because it helps define it more clearly. So what's the 0, 1, 2, 3 scale? Can you use 1 through 10? Yeah. Could it be the patient 1 through 10? Yeah. Could it be you? Yeah. But just make sure you indicate, on a scale 1 to 10, my interpretation that fixation's a 5. Make sure, that it's noted that it's you that's saying it. If it's the patient states 5. Who's the source of the data? But I like doing 0, 1, 2, 3. So I'll say the fixation, and I'll say the segment, I'll say the motion. Is it left or right? Right? I like to say which motion is restricted. Left, right, forward, back, whatever. Typically in the neck, it's like left and right. You palpate like this. Typically, low back, usually it's prone palpation. So usually it's extension, fixation. And then it's typically 1, 2, or 3. 0, 1, 2, or 3. Zeros, you can do the maneuver, and it's Foley, no problem, normal. So 3, we'll go through the legend here, but 3 is it stops you. The pain stops you from doing the maneuver. So you can't do the palpation because of the pain. Can you see how that's a good scale for functional test, orthopedic test. In other words, when you're moving, when I say functional, what am I talking about? When you're moving stuff, right? You're moving stuff. Document whatever you're supposed to, whether it's the orthopedist, positive or negative, whatever the orthopedic book says. But what do I like to add to that? 0, 1, 2, 3. So 0, and do you want the legend? Yeah, you just put in the legend. What's 0 mean? There's no pain and they can do the maneuver fully. 3, pain stops them from, they can't do the maneuver because of the pain. So what would that be with palpation? I couldn't even go in and find the fixation because as soon as I tried, the patient stopped me because of the pain. Okay? That's a 3, severity. 2, I can do it, it's functional, but it's limited. So I can't do it all the way. It's not stopping me from doing it, but I can't do it all the way. Palpation, right? I can do it, but there's too much pain for me to do it fully. 1 is I can do it fully. I can do the maneuver fully, but it's painful. Now I'm going to give you a little clue right now. I just told you the #1 finding in chiropractic. On a scale of 1 to 3 with functional capacity test after the first, second, or third re-exam. Your second re-exam into it, third re-exam into it, you think you're going to have positive range of motion 2 re-exams later? No. Guess what you'll find 2 re-exams later? You'll find a grade 1 in what test? The compression extension test and fixation test. In other words, they're what? Joint tests. So now, can I document a compression test by the first, second, or third re-exam, a possible compression or extension test? High probability and likelihood versus range of motion or muscle testing, right? In other words, I got some what? Need for care. Need for care. You don't got need for care, what do you have to do? Release them. Right? So I have the need for care. So with the orthopedic tester, I told you there's going to be the compression extension tests. So do whether they're positive or negative, and then grade them 0, 1, 2, 3. And I'm just telling you, by the time you get to the second re-exam and third re-exam, the compression extension test and palpation is going to be the 1. It's going to be you can do it, but it's painful at the end when you do it. That's a finding. That is going to be your permanent findings almost always. When you go to MMI, I just told you your permanent findings you're going to have with either orthopedic test or range of motion. That's it right there. It's going to be overpressure, compression, extension, and it's going to be the grade 1. They're going to be able to do it fully. It's just going to be painful at the end. Make sure you write down what I just said. You look for that in your exams. Now, do you have to look for it as much in the initial exam? No, they're more acute. When you got to pay a lot of attention to this? Second and third re-exam. By the time they get to the first one, they're feeling a lot better. Active ranges is either normal or close to normal. By the time you get to the second re-exam, this is where all the money's at. This is the money right here. How important, by the way, is that to the patient? That they have normal joint biomechanics. It's the #1 cause of disability in the United States, osteoarthritis. What's the #1 cause of osteoarthritis? Altered joint motion. It's a big problem. Okay? So, does that make sense?
Back on the palpation, did you ever contrast?
Always. Remember what I said about normal? Remember what I said about normal? Always try to get a normal. Normal helps to do what to abnormal? Magnify it.
But in a SOAP note, would you ever contrast that?
Yeah.
Like say, I've got mild restriction at C5 and left rotation as opposed to C4.
No, I wouldn't. I'm not going to put, I'm not just going to document things that are normal that's going to waste my time. No. There was no reason to do that at all. if there was a reason,
But on palpation, I'm just trying to.
yeah, no, if there was a reason, that, let me give you a ridiculous analogy. Then why don't we go ahead and document that his ankle's normal also? Because it's a waste of time and energy and words. That's why. So no, just find what you're going to find and document it, okay? And then quantify it. So back to the objective part, we kind of left the question, which is, when you do the objective component of a SOAP note, what are the highest probability findings? Fixation, that's a range of motion. Remember, you need 2 E&M components in the SOAP note, right? Are you with me?
E&M?
Evaluation and management.
Oh, okay, yeah, yeah.
Okay? So what is quick and simple with the highest probability of having positive findings for a typical chiropractic patient for the E&M component of the objective portion of the SOAP note? Do you want me to say that again faster? It's really 3. It's tenderness, point tenderness, pain, huh?
Range of motion.
Which range of motion? Joint motion. That's the fixation. Fixation.
You're talking about 99203, 213, that level?
I don't want to get into that. I don't want this to be a coding seminar. Okay, I want this to be a documentation clinical
You have to
seminar.
have one of the pain or the asymmetry though, don't you have to have one from the P and the A and one from the R and the T as parts?
Yeah, I'm just going over the orthopedic. We already covered the subjective, didn't we?
Yeah.
Subject already has the pain, doesn't it?
Okay.
Right?
Yep.
Now we're on the O part.
Okay.
So in the O part for the E&M, tenderness and restriction, fixation, restriction. That's typically. Anything else you guys are doing in the objective component of the SOAP note? Anything else you guys are doing? How easy is it to get the patient on a regular visit, neck, back, whatever? Okay, is that tender, Mary? And then palpate it yourself for restriction, and then just see how much restriction is it. Well, just test it. Does the restriction make her winch? That's called a 2. If they can't do it, what's the likelihood of them not being able to do it at all because of the pain? Rare. That's like a new patient. That's acute. So that's rare. So if you do it, does it make her kind of winch and stop? That's called a grade 2. Or if you do it and it's painful, Mary, is that painful? Grade 1. So now it's pain with, and then you can still have restricted motion with no pain, right? Fixation C5. But how many times are you going to have a fixation with no pain? Have you guys ever felt a fixation and it wasn't tender? Well, what's causing the fixation? Remember that thing called collagen? Remember that collagen matrix thing? So what happens when that collagen matrix is aberrant? Isn't that what causes the fixation? And so when you have that aberrant matrix of collagen, what happens to those peripheral nerve endings that are in there? Are they higher likelihood to get trapped when it moves or lower? Higher, which means what with pain? Higher likelihood with pain. So that's why almost every time you see the fixation from the collagen, it's collagen restriction that causes fixations. When you see those restrictions, that's why it's almost accompanied with pain. It's not, because it's mechanically you're trapping it. You're pushing it like this. What are you doing to the fibers? You're going like this. Where are the nerves? They're right in there, and what are you doing to the nerves? They're compressing the nerves. And that's if they're not even sensitive. They could have healed, or they're on their, when they're first coming in, the nerves are hypersensitive, right? The lower pain threshold of the nerve. So when you do this, they're going to have a lower pain threshold. If the nerves are in the matrix, and you're pulling the matrix, you'll fire them. And then because you have the matrix, what does that do to the joint motion? It restricts it. That's called a fixation. You think it might be beneficial to know how to explain that in a court? Yeah. Yeah.
So when quantifying that in the 0, 1, 2, 3 scale, then would you just kind of build that legend into your SOAP note, or you put that in every single SOAP note then?
Yeah, the legend's just in the exams. It's in the notes. The legend's just in
You
there.
put in every single SOAP note.
The legend,
Once in the in the examination and then.
More for narrative.
yeah, not really. I mean, it's in your initial, as long as it's in your initial, the legends are in your initial exam, then everything that flows goes back to the legends that's in the initial exam. That's like muscle testing. Will I put the muscle testing component in every soap note? No. Just in the initial paperwork, make sure your legends are there for everything, you know.
But for muscle testing, I mean, you're not necessarily doing that every visit.
But if you did, would I put the muscle test legend in every soap note? No. It's just in the exam sheet, all the exams, and then the legend that interpret what the heck all that is. And then down the road, you got everything to refer back to the legend.